I would like to invite the next speaker, Dr. Meenakshi Olama. She is currently head of the department at JNMC BMIMS in our institute, and she is fellow of AMASI, ACARSI, and IGS, awarded with PhD in minimal access surgery and recipient of gold medal in MPhil. Her area of interest is breast, endoscopy, and laparoscopy. She is main pillar to start the Pink Lifesaver project at our institute with as a joint venture with Rotary Club Wardha, and has screened more than 12,000 women of Wardha district for breast and cervical cancer till date. I would like to request ma'am to deliver the talk on adjuvant treatment in carcinoma breast. Over to you, ma'am.
Thank you, Dr. Darshana, for a nice introduction. At the outset, first of all, I am very thankful to Association of Breast Surgeons of India for agreeing and conducting this educational module to our institute. And I think all my postgraduate students as well as faculties and the delegates who have attended this module must be benefited till now. And I am very thankful to association for allowing me and sharing this module for delivering this talk. So I will be talking on adjuvant treatment in carcinoma of the breast. So this is the disclosure. So this is the property of APSI. I have made little modifications in this presentation. So till now, we have already discussed what are the various types of malignancies. So mostly the broadly classification of this is non-metastatic and metastatic malignancies. So the early breast carcinoma, which is a curable disease, then comes the large operable or the locally advanced malignancies, which are considered as non-metastatic, but it requires a multimodality management. The surgery is the mainstay of management, and in locally advanced, the chemotherapy is having very important role, followed by surgery along with the radiotherapy and hormonal therapy along with the targeted therapy. And when we are talking about the metastatic disease, so the surgery has very limited role. We have already discussed in metastatic breast cancer. So the main role is of chemotherapy, hormonal therapy along with the radiotherapy and the biphosphonates. So now during this talk, I will be mostly dealing about chemotherapy, hormonal therapy, targeted therapy, and the radiotherapy. So there are so many breakthroughs in this management of the carcinoma of the breast. The previous speakers have already told us how from radical mastectomy, supra-radical mastectomy, now this is the era of breast conserving surgery, and mostly even if we are going ahead with the mastectomy, we are going ahead with oncoplastic breast surgery. In chemotherapy also there are so many advances, and it's an era of now targeted therapy. In radiotherapy also there are so many advances like whole blood irradiation. It has come to accelerated partial breast irradiation. So there are so many changes, and we always remember when we are talking about the treatment modality for this carcinoma of the breast. So age of the patient and the biological character of the tumor are very important parameters when we decide the treatment of this carcinoma of the breast. Now, what are the various modalities of chemotherapy that we can give in breast cancer? So various terminologies are used like adjuvant chemotherapy, neoadjuvant chemotherapy, dose dense and dose intensified chemotherapy. Then we can give metronomic chemotherapy, salvage or palliative chemotherapy. So we will see what are exactly those terminologies. For postgraduate students, it is very important to understand what are these terminologies. So the adjuvant chemotherapy, as everybody is aware, it is the administration of the chemotherapy drugs after definitive local treatment of the carcinoma of the breast. So when we get the patient of operable carcinoma of the breast or stage 2 carcinoma or early carcinoma of the breast, if we achieve the local control, after achieving the local control control either in the form of breast conservation surgery or modified radical mastectomy, we are going ahead with the systemic therapy, mostly the chemotherapy, that is adjuvant chemotherapy, mostly we are labeling it as. Now, what are the rationale for this adjuvant chemotherapy? Initially, the breast cancer is considered to be a loco-regional disease or a local disease, but the concepts have changed. Now it is considered as a systemic disease, because by the time the tumor becomes 1 centimeter, or say it becomes on a screening program, once it becomes evident, there is already a micrometastasis from this disease. So local therapy is inadequate, and for that, being a systemic disease, you have to deal with all this micrometastasis, you have to decrease the tumor burden, and there is a definite role of chemotherapy. Now, there are so many trials. One of the trials is NSABP, and it has come with the consensus that this trial has demonstrated for the first time that the natural history of the breast cancer can be improved with some form of chemotherapy. Now, there were systemic reviews of all these randomized controlled trials, and there was an Oxford review which has indicated that the adjuvant chemotherapy that reduces the recurrence, so not only the recurrence but also the mortality, and the combination chemotherapy is more effective than a single agent. Then adjuvant chemotherapy is more effective for less than 50 years age group. It is very, very important factor. So if a lady comes with 70 years of age, so whether we should go ahead with chemotherapy or aggressive treatment for such patients. So the data says that if patient is younger or less than 50 years, you should go ahead with aggressive chemotherapy, and the older age group, you should always be little conservative. Then the taxanes improve the relapse-free and overall survival rate. Though anthracycline-based are very effective, but the taxanes are showing the relapse-free and overall survival rate improvement. Then the dose-intensive chemotherapy improved the relapse-free and overall survival rate. And ER/PR negative cases, they will get benefited more from the adjuvant chemotherapy. So we should always remember these hormonal negative cases, they are more and more chemosensitive. They will respond very well to the chemotherapeutic agents as compared to the hormonal positive cases. Now, what is the aim of this adjuvant chemotherapy? It is to control the probable metastatic disease, thereby reducing the recurrence rate and improving the long-term survival. Now, this chemotherapy has benefits both in premenopausal and the postmenopausal women, though the absolute magnitude of benefit is far more in the younger as compared to the older women. So, younger the patient, you should always be very aggressive in treating these patients with the chemotherapy. Now, when you will take the decision to use the adjuvant chemotherapy, it requires the considering and balancing the risk of the disease recurrence with the local therapy around. Now we have so much of discussion during last 2 lectures whether we should go ahead with how much should be the extent of the local therapy, how much, whether we should go ahead with chemotherapy, whether we should go ahead with radiotherapy. But there are very standard guidelines what you are supposed to do. So we should assess the magnitude of the benefit from using the adjuvant chemotherapy and the toxicity of the treatment and the associated comorbid conditions. And the decision-making process, it requires a collaboration between the healthcare team and the patients. So we have to consider the patient as a whole. So you have to consider the age of the patient. You have to consider the biological behavior of the tumor of the patient. So there are so many factors, and almost now every institute is having a tumor board, which comprises of not only the surgeon, but radiation oncologists, the medical oncologist, and everybody's decision is very, very important in deciding factor. But as a general surgeon, the patients are of our own. So we should know what should be the exact modality for that patient. Now, after adjuvant therapy, we should know about what is meant by neoadjuvant chemotherapy. So when the patient comes, and if it's a large operable malignancy, or if it's a locally advanced malignancy, and you want to decrease the tumor burden, you want to make the patient operable, then in such cases, you should always go ahead with the neoadjuvant chemotherapy. So we will first give the systemic therapy, we will give the chemotherapy, we will make the patient operable, and then we will go ahead with the surgical intervention. So the main motto of giving this neoadjuvant chemotherapy before surgery is to shrink the tumor, to increase the likelihood of breast conservation surgery, or to make a mastectomy. Means you should make the patient prepare for mastectomy so that the closure or the flaps will become very proper and the closure will be proper. Then the second important point is induction of complete pathological response. It appears to be a very predictive of long-term patient outcome. So if you give a preoperative chemotherapy, neoadjuvant chemotherapy, you can assess the response to the chemotherapy, and it is very important parameter, because if the patient is not responding after 2 cycles, you will have to shift over to a second line of chemotherapy. You have to change the regimen. So if you are giving in a post-operative period, it is very difficult to understand whether your patient is responding to chemotherapy. But if you give it beforehand, you can know how is the response to your chemotherapy, and you can identify if there is any drug resistance. Now, the another form of chemotherapy is dose dense and the dose intensified chemotherapy. So, all the postgraduate students must understand what is meant by dose dense and dose intensified chemotherapy. These are the forms of neoadjuvant chemotherapy which are nowadays routinely followed. So, if you take the example, suppose it's a epirubicin and cyclophosphamide regimen. So, what is meant by dose dense regimen, in which there is the dose remains the standard. As we are giving in a standard chemotherapy, the dose will remain the same, but the interval becomes shorter. So if in a standard dose, the epirubicin is given as 90 milligram per square meter of body surface area, and if the cyclophosphamide is given as 600 milligram per square meter of body surface area, the dosages will remain the same. But if it is given at the interval of 3 weeks, it will be given at the interval of 2 weeks. So that is known as dose dense regimen. The another terminology, another regimen that can be followed is a dose intensified regimen, in which the dosages is increased as well as the interval is shortened. Okay. So in these cases, the epirubicin, instead of 90 milligram per square meter, it has increased to 150 milligram per square meter. And the cyclophosphamide, from 600 milligram per square meter, it has increased to 2000 milligram per square meter. So these are the meaning of dose dense and dose intensified chemotherapy. So depending upon the risk factors, the biological behavior of the tumor, we can decide in a neoadjuvant chemotherapy whether we can go ahead with dose dense or dose intensified chemotherapy. The another important chemotherapy that can be given, it is a metronomic chemotherapy. So what is meant by metronomic chemotherapy? It is a low dose chemotherapy on a continuous or frequent schedule. So suppose we are giving a 3-weekly paclitaxel. So in a case of a metronomic chemotherapy, we can give a weekly paclitaxel. Instead of 6 cycles, we can go ahead with 12 cycles. So it is a weekly, daily or weekly regimen on a long period of time. And what are the advantages of this? It is having less severe side effects. Now, there is another form of chemotherapy, that is salvage chemotherapy. So the intent is not the cure in these cases. The intent is palliative. Or the salvage chemotherapy is a terminology, or it is used when all the other modalities have failed. So the chemotherapy offered when the cancer recurs or the patient is not responding to any other modality of treatment, then as a palliation, it is given in a high dose with a goal of trying to beat the cancer into remission. So that is salvage chemotherapy. Now, when we are deciding the management of this breast cancer, the two terminologies which are commonly used that we have already discussed. So what is the biological character? So what is meant by this biological character? So there are two types of factors, the prognostic factors and the predictive factors that will decide your management. So what is meant by prognostic factors? So these are the factors that predict the risk of recurrence or death from the carcinoma of the breast. The very important factor, we have so much of discussion on this axillary nodes. So the very important factor is the number of positive axillary nodes. It's a very important independent prognostic factor for the carcinoma of the breast. And another important factor is the tumor size. Though the tumor size has a relation with the positive axillary lymph node, but still the tumor size is a very, very important independent prognostic factor for the carcinoma of the breast. And the other factors include, which are the lymphatic and vascular invasion, histologic tumor type, histologic grade, nuclear grade, then estrogen progesterone receptor status, and the HER2/neu overexpression. So all these factors are very, very important in predicting the risk of recurrence or death from the this pathology. Now coming to the predictive factors. What does predictive factor mean? These are the factors that predict the chance of responding to the therapy with specific treatment. So suppose we are considering the hormonal treatment. So whether that patient will respond to your hormonal treatment or not. Suppose if we take the example of patient is ER/PR positive. So how much if you give a hormonal treatment to the patient, if you give tamoxifen or if you give the letrozole, so whether the patient is going to respond or not. So that will predict it. So if patient is a hormone receptor positive, that is ER/PR positive, there are chances of 70% chances of response to your treatment. Then if the patient is ER positive and PR negative, there will be response rate is 30 to 40% as compared to the patient is ER negative, PR positive. And if the patient is ER and PR negative, there are less than 5% chance of response to the treatment. So the hormonal receptor status is very, very important predictive factor in deciding your management, hormonal treatment. Now, coming to the next point, which patient will require chemotherapy? Are you going to give chemotherapy to each and every patient? So there are NIH and St. Gallen consensus meeting. What are the criteria that they have put forth? So if the tumor is more than 1 centimeter, so irrespective of the menopausal status of the patient, irrespective of the nuclear grade and ER/PR status, and if the patient is node positive, you must go ahead with the systemic chemotherapy. If the tumor is 1 centimeter, irrespective of menopausal status and a status with nuclear grade 3 and ER/PR negative, you must go ahead with the chemotherapy. Then standard of care for women with ER negative tumors who need adjuvant systemic therapy, that is those with positive nodes, tumor size more than 1 centimeter and having other adverse features, the chemotherapy is a must. Then benefit of adding this chemotherapy to hormone therapy for women with ER positive tumor is controversial, particularly for those with node negative disease. This point is very, very important for everyone to understand. So if the patient is ER positive and if the patient is node negative, early carcinoma of the breast, whether we should go ahead with chemotherapy or not, it's a $1 million question. And now there are so many genomic assays available that can decide whether we should go ahead with the chemotherapy or not in such early cases. And the tumors that are hormone receptor positive are less likely to benefit from chemotherapy. That is what this consensus says. Now the chemotherapy benefits at least some women with the hormone receptor positive disease, and the decision regarding adding the chemotherapy in such situations can be taken with the help of gene expression analysis. Mostly we are preferring the Oncotype DX assays. So for patients with very small or microinvasive tumors and no unfavorable features or lymph node metastasis, means having all the favorable features, all favorable factors, the recommendations for adjuvant therapy are less firm and even suggested that adjuvant therapy may be omitted for selective or very small tumors. Now, what are the various genomic assays which are available, or the molecular tools for deciding whether we should go ahead with chemotherapy or not? So there are this TAILORx, Oncotype DX, MINDAC or MammaPrint, but mostly the Oncotype DX is generally advocated. So what is this Oncotype DX? So it is the commercial genomic test that estimates the likelihood of the disease recurrence in a women with breast cancer. This is the assay, this is the genomic assay that will tell whether your chemotherapy is going to be effective or not, and whether there is going to be disease recurrence or not in a stage 1 disease, okay, or stage 2 disease. So for early carcinoma of the breast, And if it is DCIS, if it's an in situ carcinoma, so whether there is any disease recurrence, or whether if you are going to go ahead with radiotherapy, whether that radiotherapy will be effective or not, that will be told by this Oncotype DX. The test analyzes the activity of 21 genes that can influence how likely a cancer to be grow and respond to your line of management, either for early breast carcinoma chemotherapy and for a DCIS radiotherapy. So in this Oncotype DX, there is a recurrence score result which is calculated from these 21 different genes. So the 16 genes are cancer related genes and the 5 genes are reference genes. And how the result is interpreted. So there are 0 to 100 this score. So if the score is less than 18, what it indicates? The cancer has low risk of recurrence and the benefit of chemotherapy is likely to be small and will not outweigh the risk of side effects. So you should think twice before advising the chemotherapy to such patients because there is a low risk of recurrence. If the score is 18 up to 30, the cancer has an intermediate risk of recurrence. And if the score is more than 31, the cancer has high risk of recurrence and the benefits of chemotherapy as likely to be greater than the risk of side effects. So you should always advocate chemotherapy if the score is more than 31. So if the score is less than 18, you can ask the patient. Patient may not take the chemotherapy, but if the score is more than 31, patient has to take chemotherapy in spite of side effects. Now the algorithms have been already published, estimating the rates of recurrence and a validated computer-based model called as Adjuvant Online, which is available to estimate the 10-year disease-free and overall survival. So if you go on this website, you can calculate this, and these tools aid the clinician in estimating the absolute benefit of using adjuvant chemotherapy. Now, which regimen you are going to choose? So generally we are referring the patient, we are discussing in the tumor board, and the medical oncologist tells us what regimen you are supposed to give to that patient depending upon the age, depending upon ERPR status, depending upon HER2 status, depending upon histopathology report. But you should know what are the various regimens which are available. So there are first line and second line, like anthracycline based regimens. The second line, these are taxane based regimens. So there can be given in isolation or there can be given in combination. So depending upon so many factors. The commonly used regimens, these are FAC regimen, that is 5-fluorouracil along with adriamycin along with cyclophosphamide for 6 cycles. Then another regimen that can be given is FEC, that is 5-fluorouracil, epirubicin along with the cyclophosphamide. Then FEC for 3 cycles, followed by docetaxel for 3 cycles. So everybody must remember the anthracycline based regimens, the anthracycline drugs like the adriamycin, epirubicin or doxorubicin, they are having different mode of action, and the taxane group are having different mode of action. Okay, and the toxicity is also different. So it is very, very important to know the anthracycline based regimen or the anthracycline based drugs, they are very, very cardiotoxic. And if you this combine this anthracycline based drugs along with the Herceptin. Herceptin is also very, very cardiotoxic. So this cardiotoxicity, risk of cardiotoxicity becomes very much high. So when you are combining this Herceptin along with the these chemotherapeutic agents, it is always preferred to combine the taxane based chemotherapy along with the Herceptin or targeted therapy. So these are the very important points that everybody should remember. Then another regimen like AC, adriamycin, cyclophosphamide 4 cycles followed by 12 weeks of paclitaxel, which is the low dose this metronomic therapy. Then there can be dose dense chemotherapy like 2 weekly regimens AC for 4 cycles followed by paclitaxel for 4 cycles. So there are various regimens, and depending upon the patient's comorbid conditions and other factors, we can decide which chemotherapeutic regimen that patient should opt for. Now, overall data suggests that modest but significant benefit for the anthracycline containing compared to non-anthracycline containing regimens. So anthracycline containing have significant benefit, their effectivity wise. Then particularly for women whose tumors overexpress HER2. So this point everybody must remember. So the several trials now report a survival advantage for including a taxane type of drug, that is paclitaxel or docetaxel, in the adjuvant chemotherapy regimen for both premenopausal and postmenopausal women with node positive breast cancer and for those with higher risk of node negative tumors. It is very, very important point that everybody should remember. So there is a advantage for including a taxane based drugs in adjuvant chemotherapy for both premenopausal and postmenopausal women with node positive and for those with higher risk of node negative. So even if it's a node negative and if patient is having other factors, other unfavorable factors, we should go ahead with taxane based drugs. Now, as all we know, what are the various side effects that we can get with this chemotherapy? So starting from alopecia, mucositis, nausea, vomiting, diarrhea, cystitis, myalgias, neuropathies, pulmonary fibrosis. Cardiotoxicity is very, very important with anthracycline based drugs. Then local reaction, phlebitis, renal failure, myelosuppression, and you have to combat, you have to take care when you are dealing with giving these chemotherapies, especially when you are giving these dose dense or dose intensified chemotherapies. There is a severe myelosuppression, and you have to take care of that this leukopenia and severe anemia when you are giving those type of chemotherapies. Now coming to the targeted therapy, almost 1 in 5 women of carcinoma of the breast, the cancer cells have too much of growth promoting protein that is known as HER2 on their surface, and these are known as HER2 positive cancers. Why it is important to know about this, whether the patient is HER2 positive or not, because they tend to grow and spread more aggressively. So HER2 positive means it's a aggressive nature of the disease. And the monoclonal antibodies, which are the man-made versions of the immune system proteins, that is antibodies that are designed to attach to a specific target. So in this, they attach to these HER2 proteins on the cancer cells, and which help to stop the cells from growing. So that's why these are that's why it is known as a targeted therapy. So these are the monoclonal antibodies which will target this HER2 oncoprotein. So Herceptin is a very, very important revolution in the management of this carcinoma of the breast, because these tumors are very aggressive, HER2 positive, and if you add this targeted therapy, that will really help to the patients. So as we know that approximately 20% of these breast cancers, they overexpress the HER2 protein, and trastuzumab or Herceptin, it is a humanized anti-HER2 monoclonal antibody that can we can give in such cases, and the guidelines recommend the addition of adjuvant trastuzumab in all HER2 positive tumors greater than 1 centimeter, and we can combine it with chemotherapy. And we should always remember, when we are combining this targeted therapy with the chemotherapy, the combination should be trastuzumab along with the taxane based chemotherapeutic agents, because both are cardiotoxic. That point everybody should remember. The multiple randomized trials support a significant disease-free survival and the overall survival benefit from the addition of trastuzumab to this paclitaxel in the adjuvant setting, particularly for women with node-positive breast cancer. This is very, very important point, and the trials have revealed that the 52% reduction in the risk of recurrence and 35% reduction in the risk of death by addition of adjuvant trastuzumab for 1 year. So when we are talking about the targeted therapies, so the monoclonal antibodies, we already know that is trastuzumab, and the pertuzumab, and the tyrosine kinase inhibitors, which include the lapatinib, neratinib, and the tucatinib. Now, what are the problems with this trastuzumab? It is a very, very cardiotoxic that we have already seen. And another important problem with this is the cost. It's a costly drug. So affordability is a very, very major issue when we are prescribing in a case of HER2 positive patients. Now, after this, another important therapy that we can give in a carcinoma of breast of patient, it is the hormonal therapy. So what is the basis of endocrine therapy? As all you know, the breast development and function is a hormone dependent, and estrogen is a highly potent mammary metogen. And why this, it is important to know about this estrogen receptor, because estrogen receptor positive tumors, these are well differentiated and they have a low replication rate. And it is an independent prognostic variable associated with the disease-free survival. And it is a very strong indicator of response to the endocrine therapy that we have already seen. It is a very, very important predictive factor, prognostic as well as predictive factor. And the expression, it varies with the age and menopausal status of the patient. So when we should prescribe this hormonal therapy for breast cancer patients, so it is only for ER/PR positive patients, and it can be used for both pre and post menopausal women. You should always remember. So it is for ER/PR positive tumors, and it is for both pre and post menopausal women. Though the drugs are different, but it should be prescribed for both pre and post menopausal women. And the tamoxifen remains the time tested modality of management in a pre-menopausal women, and the aromatase inhibitor, it has a several advantage in a post-menopausal women. That is the thing. So what are the various endocrine therapies which are available? So in the form of selective estrogen estrogen receptor modulators, which are tamoxifen, then aromatase inhibitor, that is letrozole, which is the commonly used. Then there are androgens, prostagens, steroidal anti-estrogens, then LHRL agonist, and the gland ablation, that is ovarian ablation, or a pituitary or adrenal ablation, which can be used as in the form of endocrine therapies. Now a few words about the anti-estrogen. So what is the mechanism of action? What is meant by selective estrogen receptor modulator? So that causes inhibition of the estrogen receptor, and the examples are tamoxifen and the raloxifene. Then the aromatase inhibitor, what it does? It inhibits the estrogen synthesis, and the commonly used aromatase inhibitor is the letrozole. And the selective estrogen receptor degrader, which causes inhibition and the downregulation of the estrogen receptor. And the example is fulvestrant, which is mostly used whenever there is a failure of tamoxifen therapy. And ovarian suppression, whenever there is a blocking, it causes blocking of the estrogen production. And mostly the examples when we do the ovarian ablation, so mostly it is because of surgical excision, that is oophorectomy, or chemoablation with the help of chemotherapy or with the help of LHRH antagonist. So these are the various anti-estrogenic by ways we can, these are the various examples by ways we can achieve this anti-estrogen effect. Now the tamoxifen, it is a time-tested drug, and it is very, very commonly used drug. So we must know what are the advantages. So the reduction in the rates of recurrence and the second breast cancer, and it increased the overall survival of the patient. It also has the disadvantages like thromboembolic events and the endometrial cancer. Then the fulvestrant, it is a pure estrogen receptor antagonist, and it is mostly effective in a tamoxifen resistant tumors, and it is given an intramuscular injection. Then the another important point, so the tamoxifen, how much duration that we should give. So there are various trials on this, and the 5 year of tamoxifen, it is more beneficial than the 2 year tamoxifen, and more than 5 years of adjuvant tamoxifen, it provides no additional benefit. That's why the general consensus is that we should give this tamoxifen, we should use it for 5 years. So the point to remember, adjuvant endocrine therapy, if it's a premenopausal, at the diagnosis, we should go ahead with the tamoxifen. If it's a postmenopausal, we should go ahead with the aromatase inhibitor, mostly letrozole. So that is the point that you should remember. Now coming to the recurrence or stage 4 disease or the metastatic disease, premenopausal, you should go ahead with selective estrogen receptor modulators and along with the ovarian ablation or suppression. And if it's a postmenopausal, you should go ahead with the letrozole. Then what is the role of tamoxifen in metastatic breast cancer? It has been used in the treatment since 1970s, and the response rate is almost 16 to 56%. And this ER positive tumors, they have 50 to 60% chance of response. And the duration of therapy is 12 to 18 months, and the tumors nearly always develop resistance to the tamoxifen. Now this letrozole or aromatase inhibitors in the metastatic breast cancer, when there is a tamoxifen failure, you can go ahead with the aromatase inhibitor, and it has replaced the older hormone therapies such as progestins and androgens. So letrozole is the most preferred in aromatase inhibitors. Now, is there any role of chemotherapy in a metastatic disease? Yes, there is a role of chemotherapy. So we will advise the chemotherapy in ER/PR negative patients, visceral metastasis. So if the patient is ER/PR positive, your first choice, you should go ahead with the hormonal treatment. If the patient is ER/PR negative, your option should be chemotherapy. When there is a visceral metastasis, fast tempo of the disease, very aggressive disease, disease-free interval is less than 1 year, and if it's associated life-threatening diseases, you should go ahead with the chemotherapy. Now, a few words about the radiotherapy in a breast carcinoma. So, it's a whole breast irradiation that is commonly followed. The standard dose, it is the 50 gyri in 25 fractions or 5 weeks. And nowadays, what is followed is a hypofractionated radiotherapy. So, it's a the fractions have reduced. So it's a 42.5 gyri in 16 fractions or 3.2 weeks. So even if we have reduced the dose, so it's a hypofractionated radiotherapy, but there is no inferiority in the outcome. Okay, so that's why hypofractionated radiotherapy, it has preferred over a standard radiotherapy nowadays. Now there is a boost to the tumor bed, 10 to 16 gyri in 4 to 8 fractions. And the indications of less than 50 years, high-grade tumor, and focally positive margins. Now the chest wall irradiation, what do you mean by chest wall irradiation? So you are including the chest wall, you are including the mastectomy scar and the drain site, and you should give 40 to 60 gyri in 23 to 25 fractions. Now what is meant by regional nodal irradiation? So the regional nodal irradiation, what nodes you are going to include? You are going to include internal mammary, infraclavicular, supraclavicular, and any suspicious areas in the axillary bed for the patients with more than 4 nodes. So that is the regional nodal irradiation. So this concept is clear. Now a word about the accelerated partial breast irradiation. So this accelerated partial breast irradiation is patients for after breast conservation surgery. So it can be given to patients more than 60 years of age, ER positive, IDCR having a favorable histology, this primary surgery for unifocal stage 1 disease when the margins are negative and they are not BRCA1 or BRCA2 carrier. So in such a cases, the accelerated partial breast irradiation is advocated, but still the primary endpoint, it is still under trial. Now the radiotherapy after lumpectomy, that is after breast conservation surgery, it should be given after completion of the chemotherapy, and either you can go ahead with the whole breast irradiation, but as we have already discussed, or you can go ahead with the accelerated partial breast irradiation. So it is a form of brachytherapy. And for lymph node positive patients, you should go ahead with the regional nodal irradiation. And in the older patients, you should go ahead with lumpectomy, plus if the patient is ER/PR positive with the hormonal therapy. Now the radiotherapy after mastectomy, all the postgraduate students, they are aware in which patients you should refer the patient for radiotherapy after mastectomy. So when the patient is node positive, or even if the patient is node negative, But if the tumor size is more than 5 centimeter or a positive margin in a histopathology specimen, and only chest wall irradiation if the tumor is around 5 centimeter or a negative margin is less than 1 millimeter, then these are the indications for a radiotherapy after mastectomy. So the take-home message of this adjuvant treatment for a carcinoma of the breast, the adjuvant chemotherapy is required for all the patients with tumor more than 1 centimeter, ER negative, node positive. Always, this is very, very important point. The decision regarding adding the chemotherapy to hormone positive, node negative, small tumors, it can be taken with the help of genomic assays, that is gene expression analysis like Oncotype DX assay. The modest but significant benefit for anthracycline and taxane containing regimens, the addition of adjuvant trastuzumab in all the HER2 positive tumors greater than 1 centimeter. Then hormone positive premenopausal patients receive tamoxifen for 5 years. The new guidelines, you may extend up to 10 years. And the postmenopausal patients receive aromatase inhibitor. So the premenopausal, you should prescribe tamoxifen. Postmenopausal, you should prescribe aromatase inhibitor, that is letrozole. The hypofractionated radiotherapy preferred over standard dose radiotherapy for whole breast radiation, and accelerated partial breast irradiation to be considered for standard recommendations in the case of after breast conservation therapy for brachytherapy. So thank you very much for your patient listening, as we have exceeded the time, but I think you have bared with me. Thank you very much. So I'm very, very thankful to all the APSI executive members, all my faculties from Department of Surgery, and all the delegates who were there with us for 2 days. Thank you very much.
Good evening, madam.
Good evening, sir.
Most difficult part of treatment of carcinoma breast presented. Madam. I'm not having
excellent talk.
Time. I'm not going to ask any questions. I invite questions from others. If you have any doubts, please.
No questions.
Hello, ma'am. Good evening.
Good evening.
As usual, it's pleasure to hear you and attend your teaching classes and online lectures. So there are 2 things that I would just like to add or somehow put before the panel.
Yes.
Yeah, there are 2 trials. One is Cleopatra trial. So patients with HER2 positivity, if pertuzumab along is added with trastuzumab and docetaxel, then it has shown to be more efficacious. So this is a new thing that came in Cleopatra trial, addition of pertuzumab with trastuzumab and docetaxel. Regarding this tamoxifen trial, Atlas trial, okay. So they have. Hello.
Somebody has unmuted, I think. It's okay, you continue.
So there is one Atlas trial, ATLAS. So there they have demonstrated that benefits of 10 years of this tamoxifen over 5-year regimen.
5 years.
So,
yes.
Yeah. So these 2 trials, I just wanted to add.
Actually, carcinoma breast is such a topic. Daily there are some new trials are coming, and so you have to keep yourself so much updated. And that's why you should take always the opinion of medical oncologist or radiation oncologist. And you should keep yourself updated for this. Thank you very much. Anjali, you want to add something?
Excellent efforts from your department and yourself and Dr. Darshana madam. only thing what I could say in the concluding remarks, that your PG students are more luckier than us, because we were not having such a dedicated teachers at our times, and our fight is still continuing. So they have a lot of material in front of them. They have an ideal mentors in front of them, so they will have more bright future than us. And that is what, for I think, with the same vision you have planned this CME, and with every good thing has come to an end. So on behalf of APSI, and on behalf of you as a mentor, it was a very great experience, madam, and thank you for making this altogether a success.
Thank you. It's all because of you, Anjali. We could.
No, madam, I was just the initiator.
And I'm
Thank
having
you
a
very
very good team. You have seen, no? Dr. Shinde, Dr.
Yes,
Lampu,
yes,
Dr.
yes,
K.
yes. Everybody is so active,
So
madam.
many are
Shinde
leave.
sir, Lampu.
So many other
Yes, yes.
professors are on leave. So
Yeah, yeah. And they were very active. They are into the tune of the program. They were continuously asking the questions. They were listening very carefully. And to face such a senior teachers, it was a very great experience, madam, altogether.
Thank you, thank you. I'm lucky.
Yes, madam. Your students are more lucky than us, madam.
Okay. Thank you.
Thank you. So as everything that begins has to end, we have reached to the end of this APSI training module. My sincere thanks to all the APSI EC members and the speakers for their guidance. Special thanks to Dr. Anjali ma'am for her untiring efforts to make this event happen. I would like to thank the team from Datta Meghe Institute of Medical Sciences for their entire technical support to carry out this event. Last but not the least, my sincere thanks to all the chairpersons for their contribution, and heartfelt thanks to all the delegates for their active participation and contribution to make this event a success. So I would like to thank everyone at the end of this program, and we'll look forward to have more such sessions, more such interactive and warming sessions with APSI.
It's a grand success, ma'am. You have exceeded by one and a half hours or quarter to 2 hours. So it shows that how audience was interested and how good discussion and how well and seamless organization was done, ma'am. Congratulations to the team.
Thank you.
Thank you.
Thank you.